It's with great pleasure that I get to introduce today's keynote speaker. He is Dr. Gary Green. Dr. Green graduated from Hahnemann University in 1983 and has been a practicing internist for 33 years. He's both a fellow of the American College of Physicians and the American College of Sports Medicine. For 5 years, he served as the chair of the NCAA Committee for Drug Testing and Drug Addiction, and he's been an intercollegiate team physician since 1986, currently serving as the team physician for Pepperdine University. He maintains a clinical practice in sports medicine and internal medicine at Pacific Palisades Medical Group, and he has more than 20 published articles. Currently, he's a researcher at the UCLA Olympic Analytic Laboratory and also the medical director for Major League Baseball. And please join me in welcoming Dr. Green.
Great. Well, thank you very much, and it's really a pleasure to be here. And I also want to thank Clark Madsen, who's one of our former fellows at UCLA, for inviting me here. And when Clark, just to tell you a little story, when Clark was a fellow, I would give the fellows lectures like once a month, and we'd talk about their future plans, and Clark would tell us, we'd ask what he's going to do, and he'd say he's going to come back to Ogden in Utah, and everyone in Los Angeles, we'd kind of roll our eyes a little bit and say, oh, that sounds nice. And Clark would kind of sheepishly say, well, I'm going there for my family, and it's where, I'm from, and so I'm comfortable there. And we go, okay, that's nice. But now that I've been up here, and I actually took a really nice 6 or 7 mile walk this morning, I understand why he was doing that way, because he didn't want anybody from LA to move there. I think he wanted to keep this place a secret. And I can understand why you'd want to keep Californians out of this beautiful area. And so I'll make a deal with you, Clark. When I get back, if you agree to have me come back here again, I won't tell everybody back in LA how great this place is, and it'll be our little secret. So thank you very much. This has been really wonderful. I also want to thank Dr. Webb for that really nice introduction and listing some of the accomplishments, and I really appreciate that. But it kind of brings to mind a story that there was a doctor who goes to his rabbi, and he says to the rabbi, Rabbi, sometimes when patients come in to see me, they need these expensive medications, and they can't afford them, they're indigent, so I make sure they get it for free. And the rabbi thinks for a minute and goes, I do that. So the doctor says, well, sometimes patients come in to see me, and they can't always afford the office visit, so if they can't pay for it, I just let it go. And the rabbi goes, I do that. So now the doctor's getting really frustrated, and he goes, well, I do surgery, and sometimes I do surgery, these really expensive operations, and if the patients can't pay, I just take whatever their insurance covers, or I just let it go. And the rabbi goes, I do that. So the doctor goes, look, Rabbi, with all due respect, you don't have a medical license, you can't write prescriptions, you don't see patients, and I know that you don't do surgery. So how can you say you do all these things? He goes, oh no, I don't do any of those things, but I also brag about all the nice things that I do as well. So with that, thank you for that introduction. So before we start talking about kind of drug testing, I just want to have a little pitch from the Major League Baseball cap that I wear. We started a few years ago something called Pitch Smart, because we realized that by the time players get to the professional leagues, most of the injury patterns have already been established, and as you know, there's been a big explosion of Tommy John surgery, ulnar collateral ligament reconstructions, and we think that, and actually the biggest group that's growing is in youth that are having these injuries. So we started this something called pitchsmart.org. So anybody that works with baseball or works with young athletes, I'd really advise them to look at this. It's really great for parents. It gives you good pitch counts on how much exposure young arms should have to pitching, what age they should start throwing curveballs, how many innings and pitches they should pitch. So this is a really nice thing. So we're going to move to talking about drug testing, and I'm going to kind of give you a past, present, and future of drug testing. This is something I've been involved in for over 30 years with research at the professional level and at the collegiate level as well. So kind of the theme of my talk is every time we build a better mousetrap, the mice get a little smarter. And it's drug testing and athletes and performance-enhancing drug use is kind of a constant cat and mouse game to see who can outwit the other side. And usually the downside is usually we're one step behind and we just don't want to be two steps behind. So that's kind of the theme that we have. So well, before we start, anybody, any sports fans, anybody know who's in the top left? Who's that in the top left? Anybody? Julian Edelman. And how about the bottom right? Okay, that's Steve Pearce. He was the MVP of the World Series. So what do they have in common? Well, they both were world champions, and they were both most valuable player of their in their sport. However, there's a little differences between the sports. This is a list of NFL suspensions during the 2018 season, and you can see that Julian Edelman was actually suspended for 4 games for performance-enhancing drug use. Probably wasn't mentioned too much during the broadcast of the Super Bowl. And if you look at Major League Baseball, we had several suspensions last year as well. However, there's a big difference. First of all, we suspend people for half the season, and I'm going to talk about our drug testing program in a little bit. The other thing is we name the substance, and you're not eligible for the postseason or All-Star. So had Julian Edelman been a baseball player, he would not have been able to play in the Super Bowl or the playoffs, because in Major League Baseball we prohibit that. So let's talk a little bit about other sports as well in drugs. We've all recently heard about the Russia investigation, and this made a lot of press. There was a really excellent movie that won the Academy Award for Best Documentary, Icarus, which really, if you haven't seen it, I really recommend it. It details the extent of the Russian involvement in the state-sponsored doping. And basically, one of the things that they did is in the Sochi Olympic lab, they had a little mouse hole that they had drilled, and they would pass the athlete samples into the unsecured space, and then they would send them back with clean urine in them. And this was kind of what the mouse hole looked like in Sochi. And then these were the bottles that they broke into, and so they would identify. They knew which athletes were going to be dirty, and then they had clean urine for those athletes stored in someplace else, and then they would swap out the samples. And they used various different cocktails of anabolic steroids in order to dope their athletes. And I think this is probably the most important slide from that. This is from the McLaren report. And Richard McLaren did the investigation on the Russian doping scandal, and he and I did a talk last year. And this is I don't know how well hope you can see this, but if you look at the far left, this tells, on the bottom part, tells the sports that were involved with doping, the athletes that were doped. And on the far left, as you'd expect, you see athletics with track and field, weightlifting. But look down to the other end, to the right. You see curling, sailing, snowboard, table tennis, fencing, all sports that you wouldn't expect to see athletes doping. And the key point of this slide is that it's really not just the athletes that we think about in professional athletes. It's all levels of athletes. Actually, there was just a bridge card game, the card game bridge champion who was just found to have been using performance-enhancing drugs, and he was disqualified. There's been chess champions and other things. So it's really not just the high-level sports that we think about. So when you think about this, this is not a new phenomenon. This has actually been going on for not just hundreds, but thousands of years. The ancient Greeks would give their athletes magic potions and mushrooms to improve their performance. The Incas gave their runners coca leaves, not only as a reward, but also to improve performance. In the 1890s, people used strychnine, stimulants. Anabolic steroids entered in the 1950s. And in 1960, can you imagine in the Olympics, you're watching the Olympics, and in the middle of the Olympic track, Knut Jensen died of an amphetamine overdose in the cycling track. And that's what really prompted a lot of the drug testing that began in the 64 Olympics. And then in 1988, Ben Johnson tested positive. So this has been going on, again, not just hundreds of years, but thousands. This is a conversation between an athlete and an athletic trainer. So the athlete says, I wish to win an Olympic victory. And the trainer says, if so, you must submit to discipline, follow a strict diet, give up sweet cakes, train under compulsion in heat or in cold. You must not drink cold water nor wine when you feel like it. You must turn yourself over to your trainer as you would to a physician. And then when the contest comes, you have to dig in beside your opponent, dislocate your wrist, sprain your ankle, swallow quantities of sand, take a scourging, and then sometimes get beaten along with all that. Well, this conversation occurred in about over 2,000 years ago. And this is from a dialogue. And if you go to the Getty Museum in California, you'll see this part of a Greek urn, and this is an athletic trainer 2,000 years ago. And the way we know it's an athletic trainer is that the stick they were carrying is their equipment that they use to prod the athlete and to poke them and to get them to perform better. So that's what the athletic trainer looked like 2,000 years ago. Today they look a little different and they carry a little different equipment. They don't have the spears and the poking sticks. So again, we think about this as a new phenomena. This is Arthur Linton. He was the Welsh Grand National Champion cyclist in the 1890s, and he died of an overdose of strychnine and trimethyl, which is a stimulant that was given to him by his trainer. So this has been going on for quite some time. This is another great quote. This is Tom Simpson, is a Tour de France rider. He said, if it takes 10 pills to kill you, I'll take 9. He'd have been better off taking 8 because he died during the Tour de France in 1967 of an amphetamine overdose right during the Alpe d'Huez climb. This kind of thing where athletes are trying to get an advantage has taken a long time. The other thing that's a point I wanted to make is when we think about an athlete testing positive, we're really looking at the tip of the iceberg. That an athlete does not do this in a vacuum. They have a whole cadre of support staff. They have physicians, scientists, dietitians, trainers, peers, agents, all sorts of things that influence them. So the focus tends to be on the athlete who tests positive, but really we have to also focus on the other things that go into that. So why should we care? Why should you sit here and listen for the next 45 minutes about drugs and athletes? Well, as we'll talk about, a lot of these drugs have health and safety issues. But bigger than that is really the integrity of the sport. Because a lot of these drugs can change a sport so dramatically that it really alters the sport. And what can happen is, let's say you're an athlete and you're competing in a sport where everyone is using. Well, then you have 3 options. You can quit the sport because you don't want to take the drugs. You can continue to compete in the sport but be at a major competitive disadvantage. Or you can go against your morals and you could take the drugs. So I would argue that all 3 are poor choices, poor ethical choices. And I'll show you a little example of what can happen when there is no action taken. So one of the reasons we do this is not so much for the health and safety of the athletes, but it's really to protect the clean athletes. We're really not trying to just catch people. We're trying to make it that if you're an athlete competing in a sport and you decide, like most athletes, not to use performance-enhancing drugs, that you don't feel that you're at a disadvantage and you can feel you can compete fairly. So before we go on, we have to talk a little bit about sports pharmacology. So I hate to bring up a sore subject for anybody back in medical school that hated pharmacology, but in traditional medical pharmacology, we group drugs according to their classification. So the barbiturates would all go together, the beta-2 agonists would go together, different drugs would go with their class. In sports pharmacology, we break it down, determined why the athlete takes the drug. So we have 3 categories. The first is ergogenic, which is to improve performance. So that would be like a weightlifter taking an anabolic steroid to increase strength. The second category is recreational, and we're all familiar with recreational drugs, and athletes are at no greater risk or protected from becoming recreational drug users than the average population. Athletes can certainly become addicted just like the regular population can, and so they're not immune to the dangers of addiction to recreational drugs. And then the third category is therapeutic drugs, and this is to treat an underlying condition. So for an example, a asthmatic who uses an inhaler, a beta-2 inhaler, does it to get not to become better than their performance, but to get back to their underlying level. So here's an example of why we use this classification. Well, let's take a drug like amphetamines. Well, athletes can use these ergogenically in terms of stimulants, like Tour de France riders or baseball players will sometimes use these to increase concentration. You can take methamphetamine as recreationally that athletes will do. Or you can use them therapeutically in the form of amphetamine or dextroamphetamine salts like Adderall to treatment of ADHD. So what I would say is all three, it's the same drug, but it's being used three different ways, and I think you would agree that the approach to the athlete using these drugs would be completely different depending on the circumstances. So that's kind of how we group these. And the World Anti-Doping Agency, in order to get a drug on the ban list, it has to have evidence that has the potential for an enhanced performance, to pose an actual or potential health risk, and then it has this third category that's kind of like a vague category that has to violate the spirit of sport. So it has to have two of the three. So that's how drugs like marijuana would get on the ban list, because obviously marijuana doesn't enhance performance unless it's like eating brownies or Doritos or something. It does pose a health risk, but it violates the spirit of sport. And so by doing that, that's why marijuana is on the banned list. WADA also has a variety of prohibited substances. They group things according a little bit differently. So anabolic agents, peptide hormones, beta agonists, hormones and metabolic modulators, diuretics and masking agents, and there's certain things that are only banned in competition, like stimulants and narcotics, cannabinoids and glucocorticoids. And then the other key thing with any drug testing program is this last phrase that any substances with similar chemical structure or biologic effects, and that's because you can't name every single compound, and then also people come up with designer drugs, like designer anabolic steroids, like we've seen in the past, and this allows us to ban those even though they're not specifically banned. There's also substances that are just banned in specific sports. Does anybody know what sports beta blockers would be banned in? Shooting, correct. And the reason is because shooters try to shoot in between their heartbeat. And if you take beta blockers, you can actually improve your score by about 10%. If you lower your heartbeat to like 40, you're much more effective than it's at 60 or 80. It's also banned in golf and in motorsports, and I think bowling as well. And then they also ban certain methods. Like manipulation of blood and blood components, chemical and physical manipulation, and gene and cell doping. And this was 2 months ago. From a tip, the police raided the Austrian cross-country ski team, and they found Max Hauck with hooked up to a blood transfusion. So that's kind of a hard one to get out of. Like, you can't say, well, I don't know how it got there. It just happened in my arm. So that one was kind of caught with your pants down, so to speak. And then in Major League Baseball, we do it a little differently. We group drugs according to a little bit more towards reasons for taking. So we have drugs of abuse, performance-enhancing substances, stimulants, DHEA, diuretics, and then we also add any additional substances. Any new scheduled 1, 2, or 3 substances are automatically added to that. The NCAA has a little bit different list. They operate a little differently. They ban stimulants, anabolic agents, diuretics, street drugs, and then they list peptides, and they list anti-estrogens. And just to keep you in mind, this is going to come back to this, we're going to be quizzed on this. So just keep in mind, why would we be banning anti-estrogens? Okay, so just keep that in mind, because obviously estrogens are not performance enhancing, so why would we ban anti-estrogens? Now, the other thing is, any drug testing program has to have a therapeutic use exemption. So there has to be the possibility that some of these drugs that we list do have therapeutic effects, as we mentioned with amphetamines. So in order to allow athletes who have a diagnosed medical condition to be able to take these drugs legally, we've come up, every organization has a therapeutic use exemption that basically you have to have a chronic or acute condition, that the athlete would experience a significant impairment to their health if it were withheld. It would have to be unlikely to produce additional enhancement beyond normal health, and there can be no reasonable therapeutic alternative, and it can't be the consequence of a banned substance. So the reason that one's in place, so let's say somebody takes massive doses of anabolic steroids, shuts down their pituitary gonadal axis, then they shouldn't be allowed to take testosterone to replace that because it's a consequence of taking banned substances. So let's talk about ergogenic drugs. It's going to be my focus today. So why do athletes use performance-enhancing drugs? Well, obviously they do it to enhance performance, but look at how much that can be. So this is a result from a rowing race in Athens in 2004. So Great Britain won by 8/100ths of a second, or 2/100% of race time. So that, if you were doing a research study and you wanted to have two control groups, a control group and a research group, in order to have enough power to determine the difference between these two rowing boats, you need about the population of China. Okay, you need about 1 billion people. Now, obviously, statistically, these two boats are identical. They're statistically insignificant. They're statistically the same, but athletically, very different. One got a gold medal, one got a silver medal. So what can happen is, even though the difference, it can be minuscule, that has athletic consequences. And so that's why there's a big incentive for athletes to get that extra 1 or 2% or even 0.02%. And here's an example of an athlete's drug use. This is Bernard Cole. He's in the polka dot shirt there. He finished 3rd at the Tour de France in 2008. He actually won the King of the Mountain, which is those who does the best in the mountain stages. But he was disqualified after a positive drug test, and he passed 99 out of 100 tests. I actually had the chance to, with a group, to sit down and talk with him for a few hours, and he gave a list of what he was taking during the Tour de France. He was taking EPO, recombinant EPO, SERA, which is a continuous erythrocyte releasing agent, which is a long-acting EPO, human growth hormone, thyroid hormone. He did blood transfusions, albumin, insulin, testosterone, designer anabolic steroids, and injectable cortisone. I think he also took a Flintstone vitamin tube with that. But he went through in detail everything that he took during that race. And again, he was not detected till finally at the very end. So it just shows you that athletes, what they're taking, are very sophisticated in this. So one of the, I can't talk about all the drugs on the list, but I'm going to talk about 1 or 2. And the first is anabolic steroids, because these are well beyond just the normal athletic population. They've really gone to other populations as well. So the first thing is, we can't just call them steroids. We call them anabolic androgenic steroids, because they have both anabolic, which is building up of the body substance, and androgenic, which is causing male secondary sex characteristics. It's the anabolic part that they're taking this for, and it's the androgen that causes most of the side effects. So we have to answer 2 questions about this: is, do they work, and what are the adverse effects? Well, here's a list of some of the more common anabolic steroids that athletes use. The last 2 I put in red because even though they're very commonly used by athletes, they're actually veterinary products. Trenbolone is used in cattle, and boldenone is used in equine, in horses. But these are things that athletes, commonly take. So let's answer the question: do they work? Do they actually build lean body mass and muscle? Well, if I was giving this talk in the 1960s, I would say no, they don't work. All the studies show the anabolic steroids don't increase muscle mass, don't work. Well, the reason for that is because the studies that were done in the 1960s had 2 major flaws. The first flaw they had was they used untrained individuals. So what happens, anybody here ever lifted weights? Anybody? So what happens when you've never lifted weights before, you're untrained, and you start lifting weights, what happens in the first few weeks of the amount of weight you can lift? It goes up dramatically. So if you take 2 groups of untrained individuals, give one group anabolic steroids, the other group a control, they both increase their strength. So they didn't really see any difference. The other mistake they made in the 1960s is they gave replacement doses of anabolic steroids. So the average man makes about 10 milligrams of testosterone a day, the average woman about 1 milligram. So if you give a man 10 milligrams of testosterone, all you're going to do is shut off the testicular production, and you're going to have the same 10 milligrams. But that's not how athletes were taking these. This is one athlete, a weightlifter, of his regimen for taking anabolic steroids. So he was taking 4 different anabolic steroids, some orally and some injectable. But you can see on the far right the therapeutic dose, and you could see that he was clearly exceeding the therapeutic dose by orders of magnitude of 10 times or more. So this is how athletes were taking them, but it's not how doctors were studying them. And it wasn't until 1996 that Dr. Bashin he took experienced weightlifters, and he gave them 3 times the normal dose of testosterone. And Dr. Bashin found that, yes, indeed, if you combine anabolic steroids in supraphysiologic doses with a high-protein diet and weightlifting, that yes, you can increase muscle mass. Now, this happened in 1996. Do you think the athletes were waiting around for Dr. Bashin to do his study? So athletes were doing their own studies, so I'm going to give you that data from the quote, athlete studies. So here's the women's shot put final, 1972, and you can see in red there, in 7th place was Helena Fabingarova. She threw the shot put about 18.8 meters. And then 4 years later, she got up to 3rd place, and she had improved by almost 2 meters. So a big improvement over 4 years. Well, we know from the, once the Iron Curtain fell, we know that 1972 is when the Eastern Europeans and East Germany began giving their women athletes large doses of anabolic steroids. So not only did it help her performance, here's a picture of her in 1972. Pretty healthy looking young woman, and here she is 4 years later. Okay, so you think anabolic steroids had an effect on her? Sounds like you need more convincing. Okay, 1972 women's swimming, East Germany, no golds, no Olympic or world records. Again, we know from the declassified Stasi records smuggled out of the, after East Germany fell, that 1972 is when the East Germans began their experimentation with high doses of anabolic steroids for their women athletes. So here's the results in 1972. 4 years later, they won 10 of 11 individual golds. They set 10 Olympic or world records. It's pretty big from a country that wasn't very good in swimming to all of a sudden 4 years later. It's a pretty big jump. And then if you fast forward to 1992, when both the Germanys were reunited and they stopped their experiments, they won 1 gold and no Olympic or world records. Basically, and this is the combined East and West German team, so basically you can see that they're back to where they were in 1972 before they did that. But in the East Germans, in addition to documenting how much they gave them, they were also very good at documenting the effects on these. And despite the fact that they had their top scientists and physicians, they had significant adverse effects, including several deaths, severe liver damage, and some other things in the women athletes I'll talk about in a minute. So let's talk about the adverse effects. Well, this says, I'm getting worried about all these steroids you've been giving me, coach. Don't be ridiculous, Jennifer. So in addition to being a little humorous, this also has a point in that the effects of anabolic steroids depend whether you're a woman, a man, or a developing adolescent. Because again, we mentioned before, women make about 10% of the natural testosterone as men. So while women will get the virilizing effects, men get different effects. But there are some effects that everybody gets that we'll talk about in a minute. And these are some of the ones that really go with everything. So one of the major effects is cardiovascular. So anabolic steroids will lower your HDL, raise your LDL. Also will cause hypertension through water retention. And again, think about the reason that men tend to have more heart attacks than women. And I've actually worked with the DEA on doctors who are legally prescribing anabolic steroids. And I've probably looked at hundreds of patient records, and I've seen so many HDLs in the single digits. So HDLs of 8, 7, 9, and you can imagine what the cardiovascular risk is for that. So I know that, in my practice, all my patients want to have higher HDLs, and in this case, it really does the reverse. And we've seen cases of bodybuilders in their early 20s having heart attacks and dying at young ages. In the gastrointestinal tract, if you take these things orally, they have to go through first-pass metabolism through the liver. They can cause liver cancer, liver abnormalities, and then you get this peculiar thing called peliosis hepatis, which is the formation of these blood-pooled cysts that you can see on your left. And this is a gross section of the liver on the right. Fortunately, most of these things, except for obviously liver cancer, are reversible if they stop using oral agents. But if you have a patient who's using oral anabolic steroids, you should definitely check their liver function tests and get an ultrasound of their liver. The musculoskeletal system, what happens is the muscles hypertrophy, but the tendons don't get a increase in strength as well. So you'll get tendon injuries, tendon ruptures, where the tendon gets ripped off the bone. And not just the normal muscle injuries like hamstring strains or quad or Achilles. You'll get unusual ones like pec major. Like in this guy, you can see his right pec major is torn. And these are unusual. People will get pec major tears, they'll get psoas muscle tears, really unusual ones that you don't just see in the regular population. Well, if you remember, for those of you who are still awake, we talked about why some groups ban anti-estrogens like tamoxifen and anastrozole. So why do you think we ban those? Well, because of gynecomastia. What happens is if you're taking anabolic steroids in such large amounts in men, the liver can't process all of these, and some of them get aromatized to estrogen. So this is not a good look in a man. And so there are actually a lot of bodybuilders will take anastrozole or tamoxifen to kind of counteract this. And so that's why these are banned as well. And there's actually a plastic surgeon in LA who published an article about how to remove excess breast tissue in bodybuilders. So it's quite a common phenomenon in people who take high doses of these things. And most of the time, if you ask, they're taking anastrozole. And obviously, there's no reason for a healthy male to take anastrozole besides that. Now, women get the opposite effects. They get the virilizing, masculinizing effects. So they'll get hirsutism, menstrual irregularities, male pattern, baldness, deepening of the voice, and clitoromegaly. And many of these are irreversible. As opposed to men, where most of them are reversible, in women, most of these are irreversible. So even though some of these women may look healthy, they may not be as healthy as you think. And here's another good example. This was an athlete who tested positive for anabolic steroids and was ultimately banned permanently from sport. And this is the athlete when they tested positive, and that was in 2003. And then here she is 5 years later. And she was convicted of perjury in the Balco case. And you can see that the picture on the left, she has all of the hallmarks. She has a receding hairline. She has a 5 o'clock shadow. She has an Adam's apple. She had a very deep voice also, and so these just highlight some of the interesting thing is when she tested positive, she had the fastest race time at that event, fastest time men or women in that event in the time trial. So the other effects that we see with anabolic steroids are psychologic. You can get over-aggressiveness, that, quote, roid rage. There's also an addiction as well. Anabolic steroids are not thought of as a classic addictive substance, but in my practice, I've seen several people who fit the DSM-10 definition of addiction in that they have negative effects, they try to stop and they can't. And I think what happens is they get psychologically addicted to several things. They get addicted to the look. And you've probably all seen anorexic women patients who they look in the mirror and they think they look fat despite the fact that they're like 90 pounds. The men get the opposite. It's called the Adonis complex, and they look in the mirror and they think they look small. So you'll look at these guys who are just massive and they'll go, yeah, but my triceps is really a little small over here, and they want to take some more anabolic steroids. And they also get addicted to the aggressiveness and the look. The other population, in addition to athletes that I see this in, is policemen and prison guards. And they feel like they have to take this in order to be tough and to survive in their job. But I work with several police departments around the country and helping them in their drug testing programs. Because you can imagine that if you have a policeman who tests positive for an anabolic steroid and you don't do anything about it, and then that person shoots somebody or does excessive force, you're going to write a check with a lot of zeros and commas in it. So police departments, luckily, are starting to recognize this. The other thing that you can have is depression, and you can get, there are many cases of suicide during withdrawal. These are 3 young men who died after using anabolic steroids and killed themselves. Taylor Hooton at the bottom you may have heard of. His dad was on 60 Minutes and started the Taylor Hooton Foundation. And you can go to taylorhooton.org and get information about educating kids about the dangers of anabolic steroids. And we've worked with him. Major League Baseball, we fund the Hooton Foundation about $1 million a year to help them educate people on the risks of anabolic steroids. And this is a suicide note from a young man about 10 years ago who said, stop using steroids, they will destroy your life and anyone with you, please. So these are not to say that these happen all the time, but these are not benign substances, especially in developing adolescents who are still going through puberty and still having swings in their hormone levels. And then there's also the risk of any injectable anabolic steroids and needle sharing. We've seen cases of HIV and hepatitis, endocarditis, and impurities. Impurities are a big problem. I was working with a DEA agent, and he said about 10% of the undercover buys that he does of anabolic steroids turned out to be counterfeit and didn't contain anything. They contained like salad oil or olive oil or something, and he had a hard time explaining to his boss why he just spent $10,000 on olive oil. So a lot of these, you don't know what you're getting. You're not getting these from pharmacies. And then where do people get these? Well, this was a study from the NCAA several years ago, and at the time only about 14% were getting from the internet. I think that's changed. The sad thing about this study was that about 13% were getting them from a physician, which unfortunately is still happening. So other groups have spent lots of money on studies to see where do people get anabolic steroids, what's their source. They've spent all these time and effort doing that. So I want to share you a study I did that before I came here. So I turned on my computer, I went to Google, and I typed in buy anabolic steroids, and I got about 13 million hits in about 0.4 of a second. And my conclusion was that these are easily available, and the cost was minimal. So these things are not hard to get, and you don't have to do a lot of study to find where they get from. Well, as I mentioned before, every time you build a better mousetrap, the mice get a little smarter. So what are people turning to now as we're testing more and more for anabolic steroids? So they're using something called SARMs, which stands for Selective Androgen Receptor Modulators. And these target, instead of taking an anabolic steroid that has to find the androgen receptor, these go right to the receptors. And they can be agonists or antagonists. There's animal trials. The important thing is none of these have been approved for human use. They do have the potential to cause anabolic effects. They've been banned by the World Antidoping Agency since 2008, and Major League Baseball, we banned it in 2009. And an example of these are Andarine. They go in the androgen, it binds to the androgen receptor. And these are also, as athletes didn't realize, these are also very easily detectable by liquid chromatography mass spec. And for those of you who follow NCAA football, Dexter Lawrence from Clemson missed the national championship game because he tested positive for Ostarine, which is a SARMs. And it didn't seem to hurt his draft too much because he was still picked in the first round, so apparently it didn't seem to affect the NFL too much. But he claimed that it was from taking an inadvertent use of a dietary supplement. So let's look at that. Well, here's a study that was done just down the road in Salt Lake City at the Salt Lake SMERTL, the Salt Lake Olympic Testing Lab. And they looked at labeling of substances that were marketed as SARMs, and they're sold via the internet. And they found that a lot of them did not contain SARMs, and some of them contained things that, in addition. But the other thing that they found is that these SARMs have been found in low-risk supplements, such as multivitamins, electrolyte hydration products, B vitamins, fortified food. And so what we issued, actually Major League Baseball, we issued a directive to all of our players this past February to avoid anything unless it is what's called NSF certified for sport. So what's NSF certified for sport? So this is the MLB certification program, and you can get this, and there's an app on the phone. We started this in 2010 because we realized that athletes do need to take some dietary supplements, and we don't want them to test positive. As we showed with Ostarine, even things like B vitamins can contain contaminated amounts of banned substances. So now we're up to over 700 products. You can go to nsfsport.com, and what we tell players, if it's not NSF certified for sport, the player takes it at his own risk. And really, there's anything a player would need is on this list. And now our players are really educated to go and only take NSF certified for sport. Now you have to be careful. This is not the same as the NCAA list. So for example, the NCAA bans caffeine above a certain level, and in baseball we do not ban caffeine. So a caffeine product could be on the NSF certified list, and you'd have to be careful if you're an NCAA athlete. But we tell athletes, if you're going to take something, this is a better thing to take. Well, let's move on to, I'll talk about one other substance. We'll talk about human growth hormone. As the testing for anabolic steroids got better, athletes turned to other things, and they started turning to recombinant growth hormone. The other thing that happened is, as a lot of you in the room know, when we were doing residency, the only source of human growth hormone was cadaver pituitary growth hormone. And that was very difficult to obtain, obviously, and it was also potential for contamination with slow viruses. So the advent of recombinant human growth hormone has been great for medicine, but it's also allowed athletes to use that. So when we talk about growth hormone, it's not just one subject. It's not just one compound. It's actually multiple isomers of different sized isoforms. And is human growth hormone ergogenic? Can it improve performance? Well, theoretically it can, but no study has so far shown that. And we may be back where we were in the 1960s with anabolic steroids, where we're not giving it in high enough doses. And ethically, for those of you who do research, it's very hard to get that through an IRB, to get permission to give supraphysiologic doses of human growth hormone to healthy people. So it's very hard to know, and it may be that there's an athletic effect, but not a statistical effect. So once we knew that athletes were using this, we had to develop a blood test, a test for this. Well, you can't test urine for human growth hormone because it's like finding a needle in a haystack, and there's very little human growth hormone in urine, and it's also secreted intermittently, so it's very hard to find. So we had to come up with a blood test. Well, it turns out that the recombinant human growth hormone that you can get from the pharmacy is all 22 kilodalton isoforms, and the natural is multiple ones. So what happens is what we do is we have one immunoassay that measures the recombinant, the 22, and the other one measures the total, the rest of it. So what happens is if you take human growth hormone from the bottle, you're going to suppress your natural production and you're going to increase the recombinant. And then you get a ratio of recombinant over pituitary. So again, when you take human growth hormone, the serum, the recombinant goes up, the other one gets suppressed, and your ratio goes up. And if you're above 1.45 as a male, you're considered positive. Well, the first positive test was in 2010 with an English rugby player, Terry Newton, who the club knew was getting deliveries in the mail of human growth hormone, and so it wasn't really a random test. They targeted testing him, and it turned out he tested positive, and he admitted to using it, and it validated the use of this test. Unfortunately, he committed suicide soon after that when his career was ended, so that was an unfortunate part of that. In Major League Baseball, we actually had the first random positive test in 2011 with a Colorado Rocky player, a minor league player who tested positive. He admitted using it, and that was actually our first and last positive test. Why are there so few positive tests? Do you think the athletes, once we did the test, stopped using it? Well, the problem was with that test is it only detects use for about 48 to 72 hours at the max. So it's a very short test, so you have to just be inordinately lucky to catch somebody. So we came up with another test that is a pharmacodynamic test. It turns out that when you take growth hormone, you increase IGF-1 from the liver, and you increase procollagen type 3, which we call P3NP, from bone. And it turns out what you can do is you can measure this. And this test works up to 2 weeks after use. And it was approved at the London Olympics in 2012, and now it's in widespread use. So what basically happens, if you see that line there, if you're to the right of that line, your algorithm would show that you've taken enough HGH to increase your IGF-1 and P3NP. And if you're to the left of the line, that's normal. So we put this test into use in 2012, and it's been validated for ethnicity, for injury, for exercise, for fractures. And again, after 2 days, it's about 79% positive, and after 14 days, you can catch about 20% of the people. And this was used in the London Olympics, and not surprisingly, we caught 2 Russian Paralympians, so not the regular Olympians, but the Paralympians, who were weightlifters. They both tested positive. They did a second test 2 days later that also was positive, and both athletes admitted to using it. And this is the first and last tests that we've ever had positive worldwide in these. And now that we know what happened in Russia, it's not surprising to know that they were from Russian Paralympians. And athletes have sometimes asked about, this was a player, Ryan Madsen, who said, we're doing a lot of stuff. Why not add that last little bit of HGH, a small dose, or whatever is prescribed by a doctor? What's wrong with that? Well, what's wrong with that, to this genius, is U.S. Code 333E, which you cannot legally distribute growth hormone for an unapproved purpose. It's the only drug that I'm aware of that cannot be used off-label. As you know, physicians can prescribe anything. We could prescribe Viagra for a cold if we wanted to. We could prescribe anything that you want off-label. Human growth hormone is the only thing that you cannot legally do that for. The only thing that you can legally prescribe human growth hormone for is pediatric and adult growth hormone deficiency, pediatric short stature, small for gestational age, Prader-Willi, Turner syndrome, HIV wasting, chronic renal insufficiency, and short bowel syndrome. If you're prescribing growth hormone for anything besides this, it's not a legal prescription. And if you notice up there, I don't see anti-aging or athletic performance on there, so those would be illegal. They have to have a valid prescription. It has to be from a physician. It can't be from a dentist. It can't be from a chiropractor. It must be a recognized medical condition, and it must be for use the FDA has approved. And all of these anti-aging clinics are actually operating illegally. Again, what do athletes do? Now that we got a test for growth hormone, athletes went to something else. They started using growth hormone releasing peptide, GHRPs. They can cause a peak of growth hormone in 15 to 30 minutes. There's different ones. There's GHRP 1, 2, 6, ipamorelin. You can take it orally, IV, or through the nasal route. However, and a bad thing for athletes, the metabolites can be detected for actually more than 20 hours. They actually can be detected significantly longer than that. And if you Google it by GHRP, you get about 140,000 sites. And they're all sold for, quote, research only. Okay, so there's a lot of people doing research out there on these things, apparently. And these are being used by athletes. And we've had several positive tests worldwide for these in baseball and other sports. And this is a sad case of an Australian rugby player, John Manna, who had Hodgkin's lymphoma, was in remission, started taking these GHRPs, and it reactivated his Hodgkin's disease, and he passed away. So these things are, again, none of these are licensed for human use at this point. So now we've talked about some of the drugs. Is drug testing the answer? Well, H.L. Mencken said there's always a well-known solution to every human problem, neat, plausible, and wrong. So is drug testing the answer? Well, I'll let you guys make up your own decision. Again, every time we build a better mousetrap, the mice do get a little smarter. So it's a constant cat and mouse game of how we get around this. So when we do drug testing at the Olympic level, professional level, is witnessed testing. And athletes have to disrobe from basically the strike zone from the chest to the knees. And why do they do that? Well, athletes will cheat. We've had cases of athletes self-catheterizing, draining the urine out, and pouring somebody else's urine into their bladder, which has led to some particularly nasty urinary tract infections. There have been other ways that athletes have done this as well. And athletes have used things like the Whizzinator, which was available for quite some time. And what is the Whizzinator? The Whizzinator is an artificial penis and bladder, and it comes with a heater, so you can heat the urine up properly. It comes with artificial urine that you can reconstitute and put in there as well. And I think it was about $100 for this on the internet. And you'd say, wow, that's quite a deal for $100. Is there more? So is someone going to say it? Is there more? Yes. It also comes in colors. And so that you can, so if someone's watching you, you can make sure that your hands match the other parts. And so, however, the Whizzinator unfortunately got retired because the owner of the Whizzinator got arrested for defrauding the government on drug testing, and so he was actually, that's no longer available. And even if it was available, it really wouldn't work in our level of drug testing because it's witnessed, and you have to disrobe. So athletes at our level have to come up with more exotic things. And so this is the Makin machine, and so this was from the Athens Olympics, I think in 2004. So if you looked at that orange line there, everything to the orange line was inside the person, and in that rubber tank was a little bladder filled with urine, and that was put up the rectum, and then the rest of it was taped underneath the perineum, and then there was a little spring that you would pull to release the urine flow. And this was pulled out of two Bulgarian weightlifters. And again, how do you say, I don't know how it got there, I don't know how it's there. It's not mine. But anyway, they both lost their Olympic medals as well. So what can a urine drug test tell you? It can tell you what's in the urine sample at that time. That's all it can tell you. It can't tell you the brand. It can't tell you whether it was a pill. It can't tell you it was taken by mouth or injection. It can't even tell you how much was taken. It could have been a lot that was taken a long time ago or a little bit that was taken recently. And so all these things you can't tell from, a lot of times people will ask, well, they want to ask these questions, and unfortunately you can't tell that. The other thing is it's important to know that there are a lot of reasons for a urine test being negative. One could be, obviously, if the drug was never used. It also could have been used a long time ago and it's been eliminated. It could be below the threshold that the lab detects it at. It also could be a designer drug that the lab's not looking for. It also could not be tested in this program. For example, marijuana is not tested out of competition. It's only tested in competition. So you could have used marijuana but they're not testing for it, and your test will be negative. And it's also important to know that a lot of athletes have tested a lot while they're using various drugs. We actually had a chance to sit down with one of the members of Lance Armstrong's team, and he discussed how they would wait for the drug collector and then hide under the bed when he knocked on the door, and then they would, in the Tour de France, if they knew they were going to be tested, they would just pee in their pants right before the end of the finish line to get it all out of their system, and then hydrate again, and hopefully that they had known that. So a lot of the athletes know how long things will be in their system. So even though an athlete tests negative, it doesn't always mean that they're clean. And we've had lots of cases of athletes saying, I didn't do it, then they said I did it. And we've had that happened with Floyd Landis and Marion Jones and Alex Rodriguez, among others, who initially denied they used it and then eventually admitted to use. So it's important to remember that. Different organizations have different penalties. In Major League Baseball, the first time positive for an anabolic steroid is 80 games, second is 162 games, and the third is life. The minor league baseball, it's very similar to that. In the NFL, as we said, it's a 4-game suspension or a quarter of the season. The NCAA has a 1-year suspension, and the Olympics have a 2-year suspension. So all of the different organizations have different suspensions based on their own needs. And drug testing won't deter everyone. And I kind of break it down that there's 3 types of people. There's those who will obey the rules no matter what. There are those people who will obey the rules only because they don't want to get caught. And then there's people who will disregard the rules no matter what. And before you start thinking about, well, these athletes are terrible people and why are they using this, let's think about our own examples. Let me ask you, you don't have to answer this out loud, when do you slow down? Do you slow down when you see the sign that says speed limit 65? Do you slow down when you see it says radar enforced? Or do you slow down when you see a police car there with a radar gun? So everybody is in different categories, and athletes are really no different. The elements that go into a successful deterrence program, first of all, you have to have a stakeholder commitment. You have to have a commitment from the organization, from the athletes. There has to be transparency. The highest quality testing, and that means the collection process, the laboratory analysis, and the results reporting. Because if somebody's career is on the line, you really owe it to the individual to make sure that you're doing the highest quality. There has to be a fair and equitable appeal process and a therapeutic use exemption, and the main thing is deterrence. So what is deterrence from performance-enhancing drugs? And the reason that's different than recreational drugs is because these athletes have a very positive incentive to take performance-enhancing drugs, because they'll do better, they'll get more money, they'll get more acclaim, they'll win races. So what is deterrence? Well, the 5 things that it depends on is, number 1, if an athlete uses a banned substance, are they likely to be tested? If you are in a sport where they're not testing, there's no deterrence. If the athlete is tested, who's using, is the drug likely to be detected? Because if they know they can take this and the system doesn't detect it, then again, no deterrence. Then if the athlete tests positive, are they likely to be sanctioned? And is the sanction offset the rewards? So athletes, like most people, will do a risk-benefit analysis. And if the benefit is millions of dollars and the risk is that maybe they'll get suspended for a game, most athletes are willing to take that. And so the deterrence depends on the frequency of testing, how effective the testing is, how unpredictable it is, and how swift the discipline is. The other thing is we do need to continue to advance research in this area. We're doing a lot of research, and the main research that we're doing is through the Partnership for Clean Competition. And what the partnership is it was founded in 2008, and rather than have the different organizations do their own drug testing research, we decided to pool our resources with the U.S. Olympic Committee, U.S. Antidoping Agency, the NFL, and Major League Baseball were the initial partners, and we've now since added the PGA Tour and the NHL, and we've pooled our resources to do research in drug testing. And since we started, we've distributed over $22 million. About 43% of our research that we've funded has been adopted in labs, and we've supported more than 90 researchers across 17 countries. So if anybody here is interested in research in performance-enhancing drug use or athletes, let me know, or you can go to our website and certainly apply for that. And here's an example of a recent research project that hasn't been published yet, but I thought I would share with you. It comes again from down the road in Salt Lake City in conjunction with the Salt Lake Olympic Lab. And what we're doing is we're trying to find other ways of detecting drug use as well as increased deterrence. And so, as you saw in the picture, witness drug testing is not very comfortable. I have to actually, as part of working for the commissioner's office, I have to undergo drug testing. It's not a pleasant thing to sit there and urinate in front of somebody else. And it's not very easy either. Like you think about athletes, that athletes can't go after a game, they're dehydrated, different things. It's not an easy process. So we're looking for other matrices. And so we decided to look at oral fluid because it turns out that the plasma does transport components into the salivary gland and get released. We've also looking into exhaled breath because exhaled breath contains both volatile and non-volatile compounds. And it turns out that exhaled breath and saliva are actually pretty good for stimulant detection and cannabinoids and for marijuana. So we started, we just did 500 minor league players, and we used a Quantasol oral fluid collection device, and then we used a inhaled breath device that we used and to try to see how these work. We're still in the preliminary stages of our analysis, but it looks like that the oral fluid one works pretty well for stimulants. So it might be, the kind of thing where we can line up a whole team and test an entire team right after a game just by putting a little something in their mouth. And so we're looking into alternative matrices as well. So it's been pretty depressing talking about how athletes are constantly cheating, how we're constantly behind. And so I wanted to leave you with a positive message is, can change happen in sports? And I'll give you a couple examples. In 2007, Major League Baseball hired former Senator Mitchell to conduct an investigation of anabolic steroid use in baseball. And Senator Mitchell found 90 former and current players who had been using anabolic steroids, and he published his report. And this was in December 2007, and there I am in the front row when he was giving his report there. And what he found was that there was really a lack of effective testing program in Major League Baseball. And here were the comments around his report. Dick Pound, who was the chairman of the World Antidoping Agency, he said, "I think MLB's drug policy is an insult to the fight against doping." Representative Waxman said that MLB hasn't acted to protect the integrity of baseball. And Senator Mitchell said there was a collective failure to recognize the problem and deal with it early on. So pretty bad publicity for Major League Baseball. And just a few years later, look at the same people. So Tom Verducci said, baseball now defines the state of the art for drug policy. Representative Waxman, baseball can now rightly boast it as the best drug testing program among the leagues. And David Howman, who became the WADA director after Dick Pound, said MLB has become a valuable partner and a leader in the fight against doping. So how did we accomplish this in really a very short period of time? Well, Senator Mitchell made multiple recommendations, which we followed every one of them. We started our own investigation department, and we've had at least 6 or 7 successful investigations where we've disciplined players, not based on a positive drug test, but based on investigations. And most of these have centered around anti-aging clinics and kind of pseudo-medical personnel. We also increased our testing. So we increased our annual testing to from 5,000, which was in 2013, to now over 11,000. The penalties have gone up from 10 games to now they're 80 games. We do mandatory carbon isotope ratio measuring. And then the biggest thing, we had a shift in player perspective, that the players were really tired of cheating and they wanted a clean game. And the players who weren't using didn't want to be competing against players who were, and they wanted a fair playing field. And that's a lot of the initiatives that we have come from the players. So just to tell you about the structure of baseball, so in the Major League, we have 30 clubs with 1,200 players on the 40-man roster. They play 162 games in 186 days, so they have very few off days, and there's a very busy schedule. The minor leagues, you have one here in Ogden, 245 clubs, and the seasons vary from 50 to 140 games. And because of that, we have multiple drug testing programs. So we have the joint program, which is for the major league players because they're represented by a union. And under U.S. law, if you have a union, it's required they have to be a partner in the collectively bargained drug testing program. The minor league program, they do not have a union, and so we can unilaterally put in whatever we want. And then we have an international program where the top U.S. and domestic, U.S. and international prospects are tested before the draft to make sure that they're clean. And then we also have a partnership program with international amateurs. And in the past 5 seasons, we've conducted over 125,000 tests. We also have the commissioner's drug policy that I'm under that covers all commissioners' employees and all the club non-playing personnel. And then the umpires are also tested as well. And we have an independent administrator who does the program. It's year-round. Even though our off-season is very short, we test in the off-season as well. We also have an arbitration process if a player wants to appeal that. And we announce the suspensions, and they're without pay, and they're also publicly announced. And so last year, we did 11,000 tests. We had about 8, let me see here. We had 8 positive tests for performance-enhancing substances. And then the important thing is, this was actually from 2017, most of the players are tested anywhere from 6 to 11 times a year. And just because you're tested doesn't mean you can't be tested the next day. We actually also test pregame, we test postgame. Sometimes we test pre and postgame so that a player can't assume that if just because they got tested before a game that they could use something and not be tested after the game. So we really try to make sure we vary it so that it's an effective program. Oh, and so we had 11 positive tests, which is a 0.09% of the tests. We had 8 tests for performance-enhancing drug use. You can see we had boldenone, which is an anabolic steroid, clostebol, which is also an anabolic steroid, DHCMT, which is dihydrochloromethyltestosterone, EPO. And you think, well, why would a baseball player take EPO to increase their red blood cell count? That's usually we see that in aerobic sports like marathon running or cross-country skiing. Why would a baseball player do that? Well, they didn't do it on purpose. They went to a clinic in Mexico and the guy just injected him and he didn't know what he was getting injected with. So it was more of an accidental thing. Ipamorelin is a growth hormone releasing peptide, and stanozolol is an anabolic steroid. And then we had 1 stimulant positive. We also have applications for therapeutic use exemptions. We had 101 for ADHD stimulants, which is about 8% or a little bit less, which is about the national average for young men 18 to 25. That's about the national average for ADHD. So here's another example. Can change happen in sport? I'll give you a real-life example, a dramatic example. Anybody here ever been to the Dominican Republic? Okay, so it's a beautiful, it's a beautiful island. The gross domestic product is pretty low. There's some really beautiful resorts there, but about 35% of the people live below the poverty line, and the annual salary is about $5,000 a year. So it's really a tale of 2 islands. There's the really nice resorts, but there's also a very big impoverished area. Major League Baseball has a full staff in the Dominican Republic. All 30 clubs have academies there that sign players when they get to be 16. They provide education, housing, and training. And when I first started working for baseball in 2003, a lot of these were pretty run down. Some of them didn't have fully functional electricity and running water. Now they're nicer than college dorms. They look beautiful. They're state-of-the-art. They really are very nice operations now. So baseball in the Dominican, there's about 20% of the players in the major leagues come from the Dominican. Actually, 12% in the majors, 20% in the minors. And many of those, the average salary is about $4 million. And many of those players are some of the biggest stars in baseball. And there's a big risk reward. There's a big financial gain to get to the major leagues. And one of the expressions that you'll see in the Dominican that they say a lot is baseball is hope. That baseball gets them out of poverty and you can set your family up for not just you, but for generations to come. The other thing is the Dominican does not have the infrastructure to develop youth talent. They have what's called buscones. Anybody who speaks Spanish, from the word buscar, buscones are finders. So they find these kids at young ages, they train them until they sign, and they get a percentage of their signing bonus. And every year, Major League Baseball puts about $50 to $60 million in bonuses into the Dominican Republic. So there's a big financial incentive to be faster, stronger, and better. The other thing is anabolic steroids are not illegal in the Dominican Republic. They're available over the counter without a prescription, and there's also a very big injection culture there. So if you're sick, they give you B12 shots, they give you vitamin shots. Anti-inflammatories are injected. There's also homemade mixtures of injectable substances. And then there's the Buscones, who have a very big incentive to get these kids bigger because they'll get a bigger paycheck as well. And 99% of the positive tests we saw in the Dominican are from anabolic steroids, and most of these are very, very easily detectable. Things like nandrolone and stanozolol that have long half-lives, and so it's not hard to detect these. They're not using the designer steroids. So here's what the problem we had in the Dominican. When we first started in 2005, there was probably about a 10% positive rate for anabolic steroids, and we weren't even doing that much testing, so it was very, very high. So what we have been able to do to lower it over about a 10-year period is do some dramatic things. Well, one of the problems was when we first started, Dominican law did not allow for suspending players who tested positive. Under Dominican law, you were only able, for employees, you could either fire them, which didn't work because then they'd go sign with another team, or you could just tell them don't do it again. Neither of which was very effective. So in 2008, we had the law changed, and we started giving sanctions. And you could see that the rate of positive tests dropped. Then the next phase, we added education, sanctions, and financial incentives. So for example, if a player was drafted and they tested positive, they wouldn't get their signing bonus, and the Buscone wouldn't get his bonus. So that had a big effect. We also bumped up our education process. We started registering the Buscones, and now our positive rate is about the same as the U.S. minor leagues. It's about 0.5% for anabolic steroids. So we've really had a big success, and it just shows you what you can do if you're really committed to the problem. So to end with, look at the major doping scandals in sport. Look at the Soviet bloc and the German Democratic Republic, East Germany, Ben Johnson, Major League Baseball before 2003, the Balco scandal, human growth hormone use in professional sports, Lance Armstrong and the cycling doping, Russia that's been going on. They all involved physicians. None of these programs could have been accomplished without physician involvement. And to me, that's really depressing. And here's a quote from Rika Reinisch. She was one of the East German swimmers who said, "The coaches and doctors were our guardians, the people we trusted. I'll never know how good I could have been without drugs." And one of the things that gets quoted a lot is this study, supposed study that was done where you asked Olympic athletes, if you could take a drug and you could be guaranteed to win an Olympic medal, but you die in 5 years, would you take it? And something like 60 or 70% of the athletes said that they would take it, which again reflects people also in their 20s, not thinking long term. But the flip side of that is all these East German women, many of which have had major, major health problems for themselves. Their offspring have a very, very high rate of birth defects. Even their grandchildren now have been showing birth defects. And some women were taking so many high doses of anabolic steroids that they've now lived as men because they couldn't go back to being women. And one of the things that these women say universally now is that they would give up all of their gold medals just to have their health back. So I think that's the flip side of that as you get a little older and you see that. And then, again, as I mentioned in the beginning, we don't just focus on the athletes. You have to focus on the rest of the infrastructure that goes to allowing them. And as we talked about when we started this talk about an hour ago, and those of you who are still fortunately awake after lunch, which is a big thing, which I appreciate, we talked about how the use of cheating in sports has been going on for not just hundreds but thousands of years. Well, the good news is that the idea of playing fairly also goes back thousands of years. And it's also important to remember that while we focus on the athletes who test positive, that it's really the majority of athletes that do want to play by the rules and they do want to follow things. And I think Sophocles said, rather fail with honor than succeed by fraud, really shows you that even 2,500 years ago, the idea of competing cleanly and fairly with honor really is a value as well. And that's the reason why we do this in this field, to try to protect those clean athletes. And so with that, I'll take some questions, and I just wanted to thank Clark and Teresa and the Ogden Surgical Medical Society for letting me come here today. So thank you very much. So just raise your hand if anybody has questions. Go ahead.
46 XY females.
I don't know if those of you could hear it. The question was, can you comment on the testosterone levels in females and XXY and the recent case of Castor Semenya? And I want to thank you for bringing that up. I'll give you your check later on. So thank you for raising that issue. It's for those of you who don't know, there is a South African female runner who has very much of a male physique, and it turns out she has high levels of testosterone because she's an XXY genotype. And she had a recent case in the International Athletic Foundation and Federation, and they've said that she's now banned unless she takes hormone or drugs like probably tamoxifen that would lower, or not, sorry, anti-androgens that would lower her testosterone level to more. So my opinion about this, and I have not seen the entire report, but just based on what I've known about this, I would say I disagree with that decision for several reasons. One is she didn't do anything illegal. This is something that she's doing naturally. The other thing is everybody has advantages in sport. I mean, if you're 7 feet tall, you're probably more likely to get to play in the NBA, and and they may have higher levels of growth hormone. We're not going to ban people over 7 feet. The other thing is just because you have a high level of testosterone is not the only thing that goes into athletic success. I mean, not everybody who's 7 feet plays in the NBA, and not every woman who's XXY is an international champion. So I think that's the case. The other thing is, are we then going to start having classes of women for testosterone like we have weight classes in wrestling? So we'll have women who have 0 to 100, 100 to 400. I mean, you get into that and it really becomes, I think, a little bit ridiculous because everybody has different advantages. And the other thing is, it's not just because she has a high testosterone doesn't make her a champion. She also had to train really hard. I mean, Michael Jordan is 6'6", and there's lots of people who are 6'6" who aren't as good as Michael Jordan, but he developed his skills. And I think the other thing that's really important is to define what we like about sport. And I was part of a grant at the Hastings Center for Bioethics, and one of the first things we had to talk about is what is sport and what do we value about it? What is the essence of a sport? So what we really define as sport is really it's a competition that's along a common set of rules. So for example, why do people run, why is it a 100-meter dash? Why isn't it 110? Why isn't it 90? Well, we've all decided that it's going to be 100 and everybody's going to run 100 meters. It wouldn't be fair if some people ran 90 and some people ran 110. And so what we really like about sports is people taking their natural abilities and then developing them to their maximum. So this girl, this woman, she also had to develop her natural abilities as well, and she's obviously done really well. And then the final thing I would say is it's only a race. It's not, we're not talking about who gets into Harvard or things like that, or something, or health and things. We're talking about somebody running a race and what is fair. And I think that if my decision, I would let her compete. So anyway, go ahead.
Could you comment on false negative rates for these drug tests?
Yep.
You think of people pass a lot of drug tests before they finally get caught, it seems like.
Well, it depends on how you define like a false negative. One of the things that happens in drug testing is really about statistics. It's really a statistical model. And so you can set the threshold as high or as low as you want. So in general, what the drug testing standard has been 1 in 10,000 error. So, 0.000, the p-value of 0.001. And that's where it's been set at traditionally. So we could set it at 1 in 100, and then we'd catch a lot more people, but then you'd have more false positives. So what drug testing has done is if someone's career is at stake, we're setting it at a very high standard. So that's why there are very few false positives, because it's set at that level that when you detect somebody, it really is positive. So when you say what's a false, like for example, there was an athlete we had at the Olympic testing lab who on their first test for EPO, erythropoietin, there's a cutoff of 80% in the basic level compared to the acidic level. And her level was like 80.05%. So it was considered to be a positive test. When she had the B sample tested, it came back 79.995% below the threshold, and she was actually given a pass. because the A didn't match the B. And even though it was within error of what the machine was, it was still considered a negative test. So was that a false negative? No, that was really because of where the threshold is set. And so you can change that depending on where you want, but then we'd catch more people and we'd have more false positives. So the false negatives, it really depends on if the substance is in the urine and it's above the threshold, I would say it's detected probably 99.99% of the time. Yep. Yep. Are you talking for anabolic steroids? Anything. So the question is, what's the role of hair testing as another matrix? The problem with hair testing is several. One is that obviously it has use for a much longer period of time, and so you're not getting active use. But the bigger problems are about the quality of hair. Blonde hair is thinner than dark hair, and it turns out that it varies on the testing. So people who have dark curly hair probably incorporate more of the drug than people with thinner blonder hair. Then the other thing is, where do you take the hair from? What if people have no hair on their head? What if they've decided to shave everything? What happens then? So it becomes, and different hair on different parts of the body grows at different rates, and so it becomes a little bit of a logistical issue that way. They do use it in some cases. It's been used in some forensic things for legal cases, but I don't think at this point it would really hold up in athletic type testing. Thank you. Any other questions?
Do performance-enhancing drugs contribute to brain injury in contact sports other than going faster and hitting harder?
That's a really good question. I think it has several influences. One is, that you alluded to, is if people are bigger and stronger and faster, then the momentum forces are going to be much higher, and that could contribute in contact collision sports. In terms of can it affect once somebody has a concussion, there are androgen receptors in the brain, and so they do have a potential effect of whether that would be positive or negative. I don't think, athletes typically don't volunteer that they're taking anabolic steroids, and so it becomes very hard to determine that. But I think it's an interesting thing just because there are androgen receptors there. I don't know how you would actually study that. I don't think any IRB would let you cause concussions and give people anabolic steroids, but it's an interesting thought. Thank you.
My question is, recently we heard a lot about this during the Olympics, where Russia had originally had their whole team banned, and then some of the athletes came back. Do you have any insight into how decisions like that are made?
Yeah, what happened in that was that the Olympics decided to let individual Russian athletes compete under the independent Russian flag, which was kind of a sham because everyone knew who they were and the athletes knew who they were. It's interesting that the Paralympic Committee decided to ban the entire Russian delegation. So there were no Russian Paralympians at the Olympics. And I've talked to the person who's on that board there, and they were very clear that they didn't think that they did it, that they shouldn't be allowed. And that was, I think, the right decision. For the Olympics, they banned certain athletes that they were part of were mentioned in the McLaren report. But their decision was that they didn't want to penalize the clean athletes who were tainted by the scandal. And I was recently in London at a Partnership for Clean Competition meeting, and we had several prominent athletes there, including Becky Scott from Canada, who's been very outspoken, Edwin Moses, who's the president of the United States Antidoping Agency, and they were vehement that Russia should not have been allowed in there. And I think that the athletes that I've talked to are really furious that that was allowed, because clearly, according to the WADA code, they were in violation and they should not have been allowed to compete. Good. Any other questions? Yeah, go ahead.
So I had a question about what the status of doping is and penalties in the NBA. I didn't see that listed up.
Yeah, the NBA has not really felt that they've had as much of a problem in this, and so they have. Well, they test. I think the main part of their testing is they test rookies, and they test for cause, and then they test, I think, the first 10 days of a new contract. And then if you're negative, I don't believe that they're tested very often. And so the NBA has a relatively, they've felt that anabolic steroids and performance-enhancing drugs were not a big problem for them, so they have not really addressed it in a more serious way, and they're not a partner with us in the Partnership for Clean Competition. Does that answer your question, or what?
So if they're not testing, they may not know.
They may not know. That's correct. I think that's kind of a good way of saying it, that, you know, you don't know until you have a problem, until you had a problem. Just to give you an example, I mean, I was asked to help Major League Baseball with their drug testing program in 2003, and prior to 2003, it was thought that anabolic steroids and weightlifting would not really help a baseball player. And then that obviously changed, and when they started testing and found out that there actually was quite a bit of use at that time. And you know, now, I mean, in probably 20 years ago, most major league clubhouses didn't have a weightlifting facility, and now every single one of them has them in the visitors clubhouse and in the home dugout, as well as every team has a strength and conditioning coach as well, because people have obviously realized that there is a big value in that. Good. Any other questions?
Sorry, Chad's question just prompted. Early in your speech, I thought I detected a bias, probably because you're working for the MLB, but it seemed like you came down hard on the National Football League, their sanctions in particular.
Yeah, I think that, let me rephrase that. It's more that I'm really proud of our program. I think our program really stands above the others, and I'm really proud of where we've gotten to. The other thing that you have to realize, and again, I'm not saying that I'm critical of the NFL program, but according to the laws of the United States, any time you have a union, it has to be collectively bargained. And the NFL, while the NFL would really like to have a little stricter program, they are constrained by dealing with their union, which has not been as, their union has not been as cooperative as ours has been. And we had to go through a lot of growing pains with our union, where in the beginning our union was very opposed to drug testing, and now they've actually, in the last round of bargaining, they were the ones who actually proposed stricter penalties from their members. So I think it depends on the sport, and it depends, but because it has to be collectively bargained, the NFL, I'm sure, would like to be able to do that. We had the advantage in baseball that we had the minor leagues. And so we were able to unilaterally implement programs in the minor leagues, and then eventually, you know, as the players moved through into the major leagues, they said, yeah, this is part of our sport and we accept that. And so now it's been a very good relationship. So I didn't mean to criticize the NFL. I think they have a harder role to play with their union than we do right now. The question was about tennis and Maria Sharapova. You know, tennis, again, every sport has their own challenges. And what tennis has is they don't really have a league. They have independent players who participate in tournaments. It's not like, you know, in baseball where they have to play, you know, they're there for the full season. You know, players can pick and choose, like in golf, which tournaments they choose to play in. And so it's very difficult to have out of competition, you know, testing. You know, in major leagues, we have, you know, our season ends in September or October, depending on how far you go in the playoffs, and then it starts up again in the beginning of February. So the out-of-competition season is not very long, and we test throughout the out-of-competition season. You know, you have tennis players who may only play, you know, may only play the majors. And so during the rest of the time, it's hard to find them, and it's hard to do that. So they have a different challenge with that. With Maria Sharapova, she tested positive for meldonium, which was a drug developed, believe it or not, by the Cardiology Institute in the, I want to say Ukraine or I can't remember where it was, but it was developed essentially for heart failure. And I don't think she had heart failure. She looks pretty healthy to me. But it turns out that they were using these, giving it to athletes because there was a possibility that it could help with aerobic performance. Unfortunately for the players who tested positive, it had a very long half-life. And actually this is one of the, I talked about how every time you build a better mousetrap, the mice get smarter. This was a case where we actually anticipated this. Our Partnership for Clean Competition actually developed a method for meldonium well before it was widely being used. And so when we started testing for it, we were able to detect it very easily. And it had not only that, the meldonium, but it has a very long metabolite that can be detected for several months even. So that's why a lot of those people tested positive. Good. Anything else? All right. Well, enjoy the rest of your meeting. I really want to thank you. It's been really a pleasure. Thank you.